This is chapter 13. It's the first in a series of 6, and this is on infiltration. So all of these come off the maxillary nerve, which is the V2. The maxillary facial injections that we'll do everything on that list, except for the infraorbital. We don't learn this, as I've told you, but you do need to know what it is and that there is such a thing. So you may look at it in your book, and we'll touch on it later. So the supraperiosteal infiltration is pulpal anesthesia on a limited number of teeth, usually just one, and sometimes a little bit of the adjacent teeth. Sometimes they can get 2. This is an injection that you can give on every tooth in the maxillary quadrant. You could give 8 infiltrations, which some hygienists do when they haven't given them for a really long time. Then all of a sudden they have a patient where they need to give a block. If they're too nervous to give the block or don't feel like they know how, then they would be correct to give something that they do know and not just give an injection when they're guessing. The better alternative is to keep up with your injections and be able to have notes at your office so that that doesn't happen, because giving 3 injections with a PSA, MSA, and ASA is far better than giving 8 as far as comfort for the patient and the amount of anesthetic. So the maxilla arch is much more successful with local anesthesia. You need to know that for future quiz. The mandible is a little less successful, only because the maxillary bone is less dense. It's much thicker on the mandible for the anesthesia to have to go through that mandibular bone to finally get to the nerve and finally inside into the nodes of Ranvier. So the maxillary arch is much more successful. There's less anatomic also variation of the maxilla and palatal bones than the landmarks in the mandible. So this is the supraperiosteal. It can also be called the local infiltration, same thing. Of course, you're going to always palpate before you penetrate, and it's going to numb the pulp, the root, and the buccal periosteum. And when they're talking about the buccal or facial periosteum, they're talking about the periodontal ligament, all the connective tissue, and the mucous membrane. So it's going to give soft, in other words, soft tissue, that mucous membrane. It's going to give soft tissue and pulpal anesthesia. Contraindications, you're going to see this on almost every one. You never ever want to inject into an area of inflammation or infection. So if you want to give a infiltration to number 8 and it is highly infected and is super inflamed, you probably would want to give a block, give the ASA, because you're giving the anesthetic further away from the infection, even though it's going to numb maybe some extra teeth that you don't need. That would be the preferred. So there's dense bone covering the first permanent maxillary molar in kids and the adult central incisor in the maxilla underneath the nose. And so sometimes in those areas, if you contact bone real quickly, it's just trial and error. You'd need to come out and then readjust, and we will be there to help you do that. So advantages are that these have a high success rate, over 95%, and you're going to have to know which ones have high success rate and which ones don't. So I pay particular attention to that. That's why it's in yellow. It's technically very easy, and positive aspiration is almost negligible, although you can have one. So technique, you're going to use a 25. You could use a 27, but it's also short. On all the maxillary injections, you will be using a short. It's just an easier way to remember that. The only time you'll use a long, it will be for the IA. So all of the mandibular and maxillary teeth, you will be using a short. Possibly the buccal, you'll use a long, but on all the maxilla, you will use a short. Needles are parallel to the long axis of the tooth. You're going to insert at the height of the mucobuccal fold above the apex of the tooth that you want numb. So the target area is the apical region of the tooth. You'll need to know landmarks and target areas of where you're trying to go. And to remember this, if you just visualize where you're actually going, it's going to help you. Almost all of them, except for the IA, is going to involve the mucobuccal fold, the height of the mucobuccal fold. On this particular one, it's going to include the crown of that tooth and the root contour. Sometimes on a root can be really bulbous and kind of bulging out, and you can't get your the barrel of your needle or your syringe in between that and the lip, so you have to kind of come from the side. So it's important to know the root contour. The bevel always goes toward the bone. The red dot is toward the bone, in other words. Then everything else is pretty much the same as a basic injection. This one, you're going to hold the syringe parallel with the long axis of the tooth. Insert at the height of the mucobuccal fold. You're going to advance 5 millimeters into the soft tissue. A short needle is 20 millimeters long, so 20 or divided by 5 is 4, so you're going to have 4 sections of 5 millimeters. So you should only see the first 5 millimeters, a quarter of your short needle, going in. You're going to aspirate, and if there's a negative aspiration, you are going to deposit a third of a cartridge slowly over 20 seconds. And that's important to know also. You'll need to know at some point that a third of a cartridge equals 0.6 milliliters. All you do is there's 1.8 milliliters of anesthetic in a cartridge, so a third of that would be 0.6. So for right, and that's how you get to that number, but for right now, I basically want you to know how much of a cartridge and over how many seconds. So if the tissue balloons, you're going to withdraw the syringe slowly and make your needle safe. You want to, usually what that means is that you are too close to the surface of the tissue, that you've accidentally pulled out a little bit, and then you deposit a lot of anesthetic. It can also mean that you maybe even at 5 millimeters, but you deposit it too quickly. So it's a lot for that tissue to be able to absorb and diffuse, and so it balloons up into the tissue, but we don't ever want to keep injecting into an area that's already ballooned. We wait until it dissolves a little bit and goes down, and then may have to reinsert again. But barring that that's all good, you're going to wait, make your needle safe, wait 3 to 5 minutes. And there's the failure. Sometimes you can have excellent soft tissue, but when you go to scale, you realize that the pulps did not get it that well. And usually that's if the needle tip is probably below the apex along the root, or it's too far away, or too far just away from the apex. So you would need to redirect and go closer. So the patient is going to feel a sense of numbness of the gingival and labial tissue at the tissues at the site of the injection, which is another way of saying the gingival and the lip tissue. They will be start to get numb. So this is what it looks like. You can see that the barrel is parallel with the long axis of the tooth, and that tissue is not quite at the height of the mucobuccal fold, but it's far enough away that if you have it any further down, the needle downward toward exactly in that fold, when you penetrate, it's going to scrape along the periosteum of the bone and really hurt. So that's why we lift it up a few millimeters to the height of the mucobuccal fold, because as soon as that lip goes down, it's all going to be where it needs to be. Complications, you could be rubbing against the bone, and so you'd have to, like we said before, withdraw and reinsert further away. Or it could be inadequate anesthesia due to depositing inferior to the apex or dense bone covering the apices. So here you can see kind of what is, I couldn't find a picture of the maxilla, so this is on the mandibular arch. On the mandibular arch, you would want to be before the end of the root, because gravity on the maxillary and mandibular arches is what's at, the point is here, and when you put liquid in there, gravity's going to pull it downward. So on the lower teeth, you would want to be above either right at or above the apices of the root of like that canine or any of the teeth. And you can see that there's different variances of the lengths of the teeth. And if you were to go that far down on one of those incisors, you would be way below the apice and may not get that good of anesthesia on that patient. On the maxillary, you want to go above the apex or at the apex, because when you deposit, gravity is going to pull that downward into those upper roots and nerves. So anesthetic is deposited into the soft tissue close to the bone. It's absorbed through the pores until it reaches the nerve filaments in the cancellous bone and has to diffuse all the way through the perineurium and perilinneum and into the nodes of Ranvier. So whether you get local anesthetic successfully or not is going to depend on the diffusion of that local anesthetic through the periosteum, through the bone, and all of those little foramina and in the cortical bone. The technique is super easy. But this is not suitable for large areas, which what I've seen as test questions, which injections would not be suitable for large areas, and you would not hopefully have to give 8 if you had large area to anesthetize. You would not want to do that many infiltrations if you could do lesser through giving nerve blocks. So this would be the site of the infiltration of the teeth. You can see if we go 5 millimeters in, it encompasses kind of a fork in the road of those nerves, and then the numbing will go down into those hair-like nerves right above the crowns. So this is going to end the infiltration part, and we'll start on the next one.